Hello, my name is Peter Douglas. I'm an interventional radiologist based in Glasgow, and today I'll be speaking about MR angiography for interventional radiology procedural planning. In a nutshell, I'll be speaking about what I do now, what I hope to do in the future, and what I hope others will find out to benefit my patients. Now, here's a relatively simple case of peripheral vascular disease, an isolated right common iliac artery stenosis. Slightly complicated by the fact that this patient has an iliac mesenteric surgical bypass graft performed for mesenteric ischemia. The curve reformat here shows the iliac stenosis and the bypass graft. Now, accurate measurements here are critical because if we get this wrong, our stent will occlude flow in the bypass graft and the patient will develop acute mesenteric ischemia and will need a laparotomy to fix that. Now, the MR allowed for really accurate measurements, and here is the DSA showing that once the stent is inserted, you can just about see the markers at either end here. There's no further stenosis and really good flow through the stent, down the iliac and also up the bypass graft. Here's a slightly more complicated case where there's a mixture of both occlusive and stenotic disease, long occlusion in the right external iliac and some stenosis above it in the common. And this was treated with stent grafting all the way from the aortic bifurcation down into the common femoral artery on the right. And these are complicated cases. If this goes wrong, it can mean significant morbidity or even mortality for the patient. So MR provides really accurate measurements to allow this to be done safely. And if we pause on this, we can just about again see the end markers for the different stents that are overlapping all the way down into the groin. Now, time-resolved MR in peripheral vascular disease is very helpful because it allows pure arterial imaging even when the contrast arrives in the feet at different times. This allows reviewing without venous overlay, which makes for faster and more accurate reporting, as well as faster and more accurate procedural planning. And it has its greatest value in critical limb ischemia, that is, where there's a risk of amputation of the limb. It gives very accurate depiction of the arteries in the foot without the distraction of calcium or venous overlay that are so often seen in CT. And in this case, it very nicely shows the occluded posterior tibial artery, which went on to get angioplastied to restore flow into the foot. We knew this was our best target rather than the occluded AT because of the distal dorsalis pedis occlusion. Now, renal MRA is performed primarily for hypertension, either where there's multiple drugs used or there's a high aldosterone and renin levels. And we primarily use gadolinium enhanced MR of the aortoiliac region. It's pretty fast, it provides very good detail for highly accurate measurements of the renal arteries and any stenoses. Here's quite a young woman who has fibromuscular dysplasia. She's in her mid-20s, and you can see this classic beaded appearance in the center of the main renal artery. It's absolutely typical of fibromuscular dysplasia. These lesions usually respond very nicely to balloon angioplasty, but they may need repeat procedures over their lives, and we try and avoid stenting where possible. We also have some good non-contrast techniques for imaging the renal arteries. Here's an Inflow enhanced SSFP. Provides absolutely fantastic contrast and really good details right out into the peripheral branches. Its only limitation is its relatively limited craniocaudal coverage. So I routinely run this again lower down to make sure that there's no accessory renal arteries coming off the distal aorta or the iliacs, which could be stenosed and driving the hypertension. Now, for the thoracic aorta follow-up, MR gives us some really good options. This is a woman with a stable aneurysm of the descending thoracic aorta. She's been imaged every year or so for about 10 years, and this has been completely stable, so we haven't done anything to intervene on this. She doesn't need it, but MR provides us this reassurance that it isn't getting any bigger without using ionizing radiation. And this patient has had a stent graft inserted for a complicated type B thoracic dissection. You can see here in the static image some blooming artifact from the metal at the top end of the stent, a little bit of intima that's rocked up in the upper abdominal aorta, and an endoleak here at the top end of the stent. Now, this was known about at the time of stent insertion, but for various reasons this was left and we kept an eye on it, and it's been totally stable in the intervening years. And this non-contrast aortic imaging, it's a respiratory navigated and ECG gated steady-state free precession sequence. It provides excellent contrast and detail of the vessel lumen, and it's really helpful for younger patients where you know you're going to be imaging them quite a lot over many years to come, and you might be worried about gadolinium deposition. Now, for vascular malformations, MR is so helpful. Time-resolved imaging is completely invaluable for separating arterial from venous channels and determining the flow dynamics. You can combine it with some anatomical sequences to provide really clear delineation at the extent of the lesions, and even when patients present with a single lesion, by the time you finish the MR, you can usually find at least one, if not more, somewhere else in the affected limb. And the main question that I want to answer is this a low flow or a high flow malformation? Low flow malformations are by far the most common, and their mainstay of treatment is sclerotherapy. It's not a great treatment. You inject some highly irritant material into the vascular channels of the malformation, and it irritates them and causes them to scar and shut down. Now, if you inject this into high flow malformation, it disappears up the draining vein, ends up in their pulmonary circulation, and is every bit as bad as it sounds. Now, for visceral aneurysms, diagnosis is most commonly with CT. Patients are often acutely unwell, either with pancreatitis, following complex abdominal surgery, or following blunt or piercing abdominal trauma. In these scenarios, these tend to be false aneurysms or pseudoaneurysms. The true abdominal aneurysms tend to be incidental findings when patients are imaged for other reasons, and that's exactly what happened in this case. This is a middle-aged woman with quite a large aneurysm arriving off the SMA. Due to its size, we felt the risk of rupture was relatively high, and the patient elected to go for embolization. Here's DSA that shows the size of the aneurysm and its relationship to the SMA, as well as flow into the splenic and hepatic arteries. And despite all of those coils placed in the aneurysm sac, blood is flowing straight through it. So following this coiling, a covered stent was placed in the SMA to shut off the feeding supply to the aneurysm from the SMA side. She went for a follow-up CT to assess how well this went, and you're not really any clearer after the imaging's been performed. Nothing but streak artifact here, and you can't really see any detail of the aneurysm itself. So we performed an MR, which very clearly shows that there's still blood flowing into the center of this. Now, there is some signal dropout from where the stent was placed, and people often cite this as a reason why MR is not good for following up these sorts of cases. However, the MR didn't have any of the streak artifact on the CT, and very clearly shows the feeding vessel, which allows us to plan a second embolization procedure to completely close this off. Now, MR imaging of the gonadal vein, what we're really talking about is something called pelvic congestion syndrome. It's a very difficult to diagnose disorder. It's confined exclusively to women. The equivalent in men is testicular varicocele. Now, it's difficult to diagnose because there are a lot of different causes of pelvic pain or discomfort, and most of them don't have specific imaging findings. Add to that that engorged pelvic veins are pretty common in women who have no symptoms at all, and it means that MR provides a very specific, unique opportunity to diagnose this in the form of time-resolved imaging. This shows a retrograde flow down the left gonadal vein, cross-filling through the pelvic veins, and then draining antegrade cranially through the right gonadal vein. In this case, you can just about also see a little bit of high signal appearing right down here. This is actually in the right side of her labia, and that's actually what this woman presented with, vulval varices. She had originally had some sclerotherapy to this area, which wasn't particularly helpful, and look at the MR, you can see exactly why the high pelvic pressure is transmitted downwards, and these varicosities are not going to get better with localized treatment. You have to embolize off the draining vein inside the abdomen. Now, what I hope to do next is some calcium imaging, and again, a lot of people tell me that MR isn't very good for calcium imaging, but those who are familiar with the SMRA and the work presented here will know that that's not necessarily true. One of the best ways is an in-phase proton density stack of stars, and you can see excellent correlation between calcium in the right common iliac artery here between the CT and the MR sequence, as well as thin linear calcifications down here at the iliac bifurcation, small things up in the aortic wall, and absolutely fantastic delineation of the detail of the bone, not only separating the coracle from trabecular bone, but details of individual trabeculae that make up the bone texture. Now, what I hope others will find out, that's really some of the work that's happening now with 4D flow, looking at both type B aortic dissections and mesenteric ischemia. Now, most type B aortic dissections are treated with medical management and are followed up to look for aneurysmal dilatation of the aorta. If that happens, then they're going to need a TEVAR. It's much more difficult to insert a stent graft once the aneurysm is formed. The geometry changes and everything becomes larger and baggy. If 4D flow can accurately identify which patients are likely to progress, then they can get definitive treatment in the acute stage when things are still small and the morphology is much more suitable to treatment. And in the context of mesenteric ischemia, these are high-risk interventions. And if we can accurately identify those patients who, following a meal challenge, do not increase flow in their portal veins, then we can perhaps more accurately identify which patients are most likely to benefit and target our therapy in a more accurate way. So in summary, MR angiography is very accurate and it's well suited to procedural planning for interventional radiology. There are many situations where MR is clearly better than other imaging modalities, and there's potential for additional patient benefit from future research. Thank you very much.